My name is Moira Stewart, and it's been my very great pleasure to have co-supervised Dr. John Campbell for the last few years for his master's thesis, Master's of Clinical Science. And I want to start by telling you a little bit about him. But first, I just wanted to say what a joy it's been to work with him. He's a hero in rural family practice in Newfoundland. He's very, very well respected and, kind of runs the show in the central Newfoundland. So I just want to tell you what his background is. John Campbell has a Bachelor of Science from UVic and then did his medical degree at Memorial and his family practice residency, all at Memorial University. And then he came here for the third-year emergency third-year residency in emergency medicine. And that's how he got to know London, Ontario, and then joined the MClSc program. Currently, he has a GFT, Geographic Full-Time Position, at the Memorial University. He's an Associate Clinical Professor. He's based in Grand Falls, Windsor, which is not on the West Coast, not on the East Coast, but right in the middle of Newfoundland. And John, before medicine, had more than a decade of military service, for which he received 6 medals. And I'm going to tell you about one of them, the United Nations Peacekeeping Medal in the former Yugoslavia for work in the mid-1990s. So it's my very great pleasure to introduce John and let you hear about his Master of Clinical Science research.
Thank you very much, Maura. And I'd like to thank all of you for taking time out of your busy day to come to my presentation today. It'll consist of about a 20-minute didactic presentation, and then we'll have some time for questions. And what I'd like to speak about today is the impact of electronic medical records on the management of adult patients with type 2 diabetes by family physicians in rural Newfoundland. To provide a bit of an overview, the study was designed to determine whether the use of advanced features in electronic medical records in primary care settings could improve the processes of delivering diabetic care in such a way as to produce improvements in physiological outcome measures in adult patients with type 2 diabetes. The study was a longitudinal study of before and after design conducted in primary care clinics that had established electronic medical records and followed 310 patients for a total of 2 years. Now, before I go any further, it's my turn to do some acknowledgments and offer some thanks. And I'd like to wholeheartedly and sincerely thank both of my supervisors, Dr. Moira Stewart and Dr. Marshall Godwin at Memorial University. And if it wasn't for their support and understanding during the design, execution, and write-up of the research, I'm quite confident I wouldn't be standing before you nice people here today. I'd also like to support my family for all of their support in not just writing up the thesis, but actually the entire master's degree as well. And I'd like to just thank my IT guy, Phil LeBlanc, who helped to develop the tool that we used, and without him, it never would have gotten done. So, by way of introduction to the topic, as pretty much everybody in this room is aware, electronic medical records are computer-based patient records that detail patient demographics, medical and drug history, and diagnostic and laboratory testing. And they're described in the literature as potentially being transformative in nature, with the potential to fundamentally change the work, the productivity, and the processes within community-based practices. And we think that that has the potential to facilitate an enhanced delivery of healthcare services. Now, diabetes in and of itself presents an ideal disease entity to actually study electronic medical records with, because of its prevalence, its significant morbidity and mortality, the availability of excellent clinical practice guidelines, and affordable, effective, and easily tolerated medications. So it provides us with an ideal opportunity to incorporate health information technology into the provision of primary care medicine. Now, the literature. Prior to designing the intervention, literature search strategy was designed to answer the clinical question as to what impact an electronic medical record has on the management of adult type 2 diabetic patients by family physicians in the primary care setting. An electronic search was done of PubMed, Medline, Embase, and CINAHL. The mesh headings that I used included, but were not limited to, diabetes, diabetic, electronic, computer, electronic medical record, family practice, primary care, and community clinics, and a combination of those terms as well. Ultimately, what I was able to find was 313 abstracts, all of which were screened, and 283 of them were actually excluded. The reason to exclude them was if they weren't published in English, hadn't been published in the last 10 years, didn't involve adults with type 2 diabetes, and weren't actually within the primary care clinic setting. So that left me a total of 30 papers, full papers that were all reviewed, 21 of which were also excluded based upon the same criteria, and ultimately I was left with 19 articles, 9 of which were review articles, 9 of which were articles detailing a process and outcome measures, and 1 article that just dealt with some outcome measures. If I could summarize 19 papers in 3 bullet points, these would be the points that I would choose to summarize them in. The first is that the use of an EMR is insufficient in and of itself to ensure high-quality diabetic care. The second thing that came out of the literature is that efforts to expand EMR use in diabetic management need to focus not just on improving the technology itself, but actually on developing methods for implementing and integrating this technology into the primary care practice reality. And that is a practice reality that is characterized by short clinical visits, multiple morbidities and medications, equal and competing agendas between the patients and the physicians, and unfortunately a certain degree of clinical inertia. And then the final point that I wanted to bring to your attention is that using the EMR to produce 2 things, diabetic registries and delivered care plans, are associated with the greatest improvement in the physiological and metabolic outcomes. Now, the intervention. The intervention under study in my research was an advanced disease management tool. So this was basically taking an existing EMR and developing some of its more advanced features, specifically identifying all of the patients with diabetes and creating a diabetic registry, providing structured diabetic visit notes for each clinical encounter, preparing standardized consultation letters, and preparing standardized laboratory requisitions. The most important thing, though, was that this advanced tool actually populated diabetic flow sheets. Unfortunately, the EMR implementation that the research was conducted with did not have lab and diagnostic imagery interface. So at no point did the labs automatically populate physiological outcomes into the EMR. And what physicians had to do previously was use 2 different systems in order to actually do this. And we know from the literature that the flow sheet that plots out trends in metabolic outcomes over time is one of the most important tools to have in an advanced disease management tool. Now, to be more specific, the independent variable was defined for this study as the patients for whom this tool was used at least once during their clinical encounters versus the patients for whom the tool was not used at all. Now, the setting. Study was actually conducted in 2 primary care clinics in central Newfoundland that had established electronic medical records. Just by way of background, in 2008, 7 physicians from 3 different clinics came together in a brand new clinical entity, with the idea being that they were going to change the way primary care services were delivered in Newfoundland. Part of that involved an electronic medical record. So this was actually, and continues to this day to be, the single largest physician-only funded EMR implementation in the province of Newfoundland and Labrador. As the clinic actually grew, it outgrew its space, so it was necessary for us in 2012 to open up a second clinical space that's literally is directly across the street from the existing one. So no patients were inconvenienced in the formation of a second clinic. Now, the community is Grand Falls, Windsor, and it's classified as being a rural community, and demographically it's very similar to all of the other rural communities within Newfoundland and Labrador. The selection of participants. So every patient rostered to each and every one of the physicians participating in the study had their electronic medical record reviewed. We were looking at the cumulative patient profile for the ICD-9 code 250, which indicates diabetes. I looked at the medication lists for diabetic-specific drugs, looked at clinical notes for descriptions of diabetes, and laboratory requisitions and consultations pertaining to the management of diabetic patients. Now, this is a methodology that was first advanced published in an article in the American Journal of Managed Care, and it has a sensitivity, specificity, and positive predictive value of 0.91, 0.99, and 0.94, respectively. So using that methodology, I identified 935 patients. 625 of those patients were actually excluded from the study. The reason that they were excluded is that they weren't type 2 diabetics. They were type 1 diabetics, they were individuals with gestational diabetes, individuals who had impaired fasting glucose, or individuals with an impaired glucose tolerance. People were also excluded if they were less than 18 years of age, 18 years being the identifying age for being an adult. They were excluded if they were not seen regularly in clinic on follow-up, and unfortunately some people had to be excluded from the study because they died during the study period. So that means that a total of 310 patients were actually included in the study. Now, there were 2 dependent variables that we actually measured. The first was process of care, and the second was physiological outcomes. Now, process of care was measured by the proportions of patients who had the recommended number of tests performed in the year that the intervention was under study. And physiological outcomes are measured by hemoglobin A1C, LDL, and blood pressure. So the plan of analysis was designed to test 2 hypotheses. The first was use of the tool is associated with the proportion of patients that with the recommended number of tests performed in a year. And the second was that the use of the tool was associated with changes in values in hemoglobin A1C, LDL, and blood pressure. We compared the 2 groups of patients on a number of different characteristics, which included sex and age, baseline LDL, baseline hemoglobin A1C, baseline systolic blood pressure, and baseline diastolic blood pressure, as well as the number of visits during the actual study period. What we actually found was that there were some differences between the intervention group and the comparison group. The mean age of the intervention group was 4 years older than the mean age of the comparison group, and the comparison group had more people with their systolic blood pressure at target. Now, to control for potential confounders, age, sex, and number of visits, logistic regression was conducted for all of the 7 outcomes. And again, just by way of review, there were process outcomes, of which there were 3, ordering of A1C, ordering of LDL, and measurement of blood pressure, and physiological outcomes, of which there actually were 4, A1C, LDL, systolic blood pressure, and diastolic blood pressure. And with the physiological outcomes, we additionally control for potential confounders by looking at the baseline value of those physiological parameters. Now, this chart here actually shows you the results of the process outcomes after being subjected to univariate analysis. And I'll direct your attention to the far right column that actually shows in terms of measurement of A1C, there was no difference, but there was a significant difference in the measurement of LDL and of blood pressure. This next table, again, looks at the physiological outcomes after they were subjected to univariate analysis. And again, I'll direct your attention to the far right column that actually shows no difference in the proportions. Now, this table details the results that we actually found once everything had been subjected to multivariate analysis. And it's interesting, in terms of process outcomes, we actually see that when the tool was used, the likelihood that LDL was going to be measured was increased by 4.7. And the likelihood that blood pressure was going to be measured was greater by 2.2. With regards to physiological outcomes, there was an increase in the proportion of patients with the LDL at target at the end of the study, and the p-value here was actually 0.046. So, discussion. From the literature, we know that the successful use of advanced EMR tools in guideline-based chronic disease management requires 3 things. You need to have user-friendly technology, you need to have expert training, and you need to have a solid change management process. And what we saw in the study was that we actually had 1/3 of all of the diabetic patients that were under care were actually had the template applied to their care on at least one occasion. From the literature, we also know that it's reasonable for us to conceptualize the treatment of diabetic patients in both a serial and progressive manner. And what we actually saw in the study was that the process of care are more easily and more likely to be impacted than physiological outcomes. We also know that basic record-keeping functions that do things like document clinical encounters, order labs and medications, and identify patients as part of a diabetic registry are important in producing the desired results in the management of chronic disease. And what we found is during the study that there was an actual increase in the number of times the LDL was measured and an actual improvement in the LDL values. And then finally, from the literature and from the study, we saw that developing a diabetic registry that risk stratifies patients based upon their clinical outcomes and allows us to plan for more intensive investigations or interventions, rather, of the individuals who aren't at target is actually quite important. So now on to the practical practice implications of the study that I've done. I think it's reasonable for us to conceptualize maturity of EMR use as actually being an emergent property, and that this emergent property arises out of three separate domains. And those domains are functionality, breadth, and outcome. And we describe functionality as providing the clinician with the right tool for the right patient at the right time. And we describe breadth of use being those tools being applied to a large population of patients with the particular condition under study. And then if we do those two things, what we'll actually see is that there'll be an improvement in the process of delivering care, so process outcomes, that then set us up to potentially be able to improve the physiological outcomes. Processes first, physiological second. The second thing that's particularly important is that the successful EMR implementation of guideline-based chronic disease management is multifactorial. And it involves us to be thinking about the technology itself, the training of the physicians in how to use the technology, leadership in clinical excellence, and the individual character of each ambulatory practice. And the final thing is that if we want to make this work, a solid change management process is required. And that brings me to some thoughts about future research. I think we might benefit from doing research into the characteristic of physicians and practices that would lend themselves to advanced EMR tools. And I think once we identify the physicians and the practices that are ready to change and ready to use these tools to a fuller and richer extent, then it would be useful for us to develop audit tools to identify areas within those given practices that would benefit from these type of interventions. If a clinician has a large volume of mental health patients, perhaps that's not the physician to bring a COPD intervention to. And then the final thing that I think that we really need to do is it would be useful for us to do some research to identify the optimal number of advanced features that could be used in any particular tool during a clinical encounter. Just because you can develop a tool that does 5 things doesn't necessarily mean you should have developed a tool that could do 5 things. So in conclusion, electronic medical records are physician-centric, computer-based products that contain demographics, medical and drug history, as well as diagnostic and laboratory information, all presented in a manner that may or may not promote chronic disease management. The meaningful use of electronic medical records in primary care is possible through a process of maturity by design, which is an individualized approach looking at the needs of a given physician and their practice, and by marrying the two, aid EMRs in achieving their full potential. So that concludes the didactic portion of my presentation, and I would be only too happy to answer any questions that anybody may have for me.
Thank you, Dr. Campbell. Well done, well timed. I'll facilitate the questions. I have a questioner here and another one there.
You had 310 patients. How did you divide them into 2 groups?
How did I divide them into the groups?
How were they divided into the 2 groups?
Oh, that's an excellent question. They were divided into the 2 groups based upon whether or not their physician, the most responsible physician, actually used the advanced disease management tool. So they weren't randomized They weren't randomized to individual groups. It was if the physician used the intervention, they went into the intervention group. If the physician didn't, they didn't.
Thank you. Second question here.
I'm curious about, I don't think it was in your data, but you didn't show any change in the hemoglobin A1C. And what levels of hemoglobin A1C are we talking about in your practice domain, both of controls and steady group?
So you're exactly right. We did not see any change in the hemoglobin A1C. And interestingly enough, Dr. Sangster, if you look at the literature, they didn't see much changes in hemoglobin A1C over most of the studies as well. What you find is that the interventions, and the intervention that I developed as well, are very, very good at getting people to order the test, but they seem to not be able to transition past the clinical inertia that exists to intensify the treatments necessary to change the values. So what we were finding, it's not actually documented in the thesis, but based upon the clinical experience and what I went through, the hemoglobin A1Cs were not particularly good. It was not unusual to see them being greater than 8, and some of them as high as 12 and 14.
One could imagine a subsequent analysis that would divide by the 14s, you know, versus the 7.7s that were kind of on the border.
Yeah.
But that's a good answer. You gave Dr. Sangster the information you needed. Any other questions? Dr. Brown?
John, I'm just curious what your thoughts when you studied these patients for how long a period of time?
So it was a longitudinal study,
Yep.
before and after design, 1 year of observation with the physicians doing what it is that they do. Then there was 1 month of the actual the deployment and education of the intervention,
Right.
and then a year after that.
So I'm just curious, and this has been my experience, that when we're looking at metrics, that sometimes the outcomes are not ready yet. That you don't have, like, a year, is a year long enough? Do we need 2 years, 3 years? And I think that we're being pushed by governments to do quick turnarounds, and I don't know if we've got the right data for it. I'm just curious what your thoughts about that.
I think you're exactly right. And when I look at some of the studies in the literature that were particularly impressed me, they actually went on much longer. But with that, they actually had more intervention. So we're going to do a low fidelity intervention initially, and then we're going to come back and we're going to do something a little bit more intense, and then we're going to come back and we're going to do something a little bit more intense. And when you did that, it was possible to have the study period be much longer because people were constantly being refreshed. The challenge that I got into with my study, to be honest with you, is it was 7 colleagues, and in very, very busy clinics. So getting them to sit down and have another intervention and another intervention and another intervention over a period of 2 to 3 years would not have allowed me to achieve the F in the finer criteria, which is feasibility. It would have been a better study, but it just wasn't going to get done in Grand Falls.
Well, no, and you needed to finish your master's.
And I was...
Stop paying that tuition.
Yes, well, Sonny's an examiner, so you're going to have to wait, unfortunately, Sonny. Dr. Sajak has a question. Any other questions? John Sangster.
Curious about
last question.
the blood pressure.
Yes, sir.
What was the difference between the groups, the behavior of the physician that you showed there was a difference in the...
Well, what we actually found is, and again, there's a concept of maturity of EMR use. And sometimes what you'll see is that the physicians will use the tool to the extent that it allows them to duplicate what they had done on paper. And that's where it stops. So if the clinician is able to generate a SOAP note and write a prescription and do a requisition, we're done. I don't want to learn anything else. That's all I can handle. So what we're actually finding, in all honesty, is that the blood pressures previously to the use of the advanced tool weren't being recorded and consistently. And then once we actually brought in the tool, that made it easier and provided a visual reminder in terms of here's a box that you need to fill in, that we actually found that there was an improvement in the measurement of the blood pressure, and that's what we saw with the 2.7. Yeah.
Great. Well, thank you very much, Dr. Campbell, and thank you, audience, for being here. It's your time to leave now, and the in-camera examination will proceed. So thanks very much.
Thank you.